Next, I am very delighted to introduce one of our presidential guest lecturers, Dr. Gunnar Hagglund. Please come on up to the podium. Professor Hagglund is a practicing pediatric orthopedic surgeon at Lund University and Skane University Hospital in Lund, Sweden. Professor Hagglund was one of the initiators and creators of the nationwide quality registry and secondary prevention follow-up program called CPUP, a program that actively follows and treats 95% of the Swedish pediatric population with CP. This is really an amazing vision because it's allowed the team to really accumulate information on natural history and outcomes related to treatment interventions. Professor Hagglund has been the director of CPUP for the last 20 years, and during his leadership, CPUP has expanded to include persons with CP across the lifespan. The program has now spread to be implemented in Norway, Denmark, Iceland, Scotland, and New South Wales, Australia. Welcome to the podium, Gunnar.
So thank you for this kind invitation to this excellent meeting. I will present our follow-up program for people with cerebral palsy. This program was started 20 years ago in southern Sweden. The reason why we started it was that we met these individuals. We met people with painful hip dislocations, and we met people with severe scoliosis, severe kyphosis, people with severe contractures and windswept deformities. And we asked ourselves, why did this happen? Could we have done anything differently to prevent this? Was there anything in the way we worked that could be changed to give these people a better outcome? This is a child with an equinus foot. If we don't treat that now, it could increase and spread to the surrounding joints and end up like this. This is a child in GMFS level 5 with a knee flexion contracture. If we don't manage that, the imbalance and the gravity will make the legs tilt to one side, and that could be the beginning of a windswept deformity. A hip like this in a child in GMFS level 5 will go on to a hip dislocation if we don't prevent it. This scoliosis in a non-ambulant child have a high risk of progress if we don't manage it, and it could end up like this. A contracture or a deformity usually starts slowly, but then it increases more and more rapidly. And the strategy with our program is to find the problems at the yellow stage and try to prevent it from going red. This is like a traffic light warning sign system, and I will explain that more in detail later. So these are all examples of red situations where it has gone too far. And it's a big challenge to treat these situations, these problems, both for the child and for the family and for the treating team. And these are examples of yellow stages. These are all quite easy to treat, but the challenge is to find them at this stage. So this is the background why we started this program in southern Sweden in 1994. This area has about 1.3 million people. The strategy was to identify all children with cerebral palsy in the area and follow them in a standardized way, and by doing so be able to detect a problem at an early stage and prevent it from going red. Our goals were to try to prevent hip dislocation and try to prevent severe contractures. A hip dislocation is often painful, and if a hip dislocation in a child with a high muscle tone usually gets deformed during its growth out of the joint, and if a femoral head looking like this, I think it's too late to reduce it and have a pain-free mobile hip. And hip dislocation, it creates a series of problems. Many of them have pain, as I said, and the pain increases the muscle tone. And this combination gives these children a high risk of developing contractures, windswept deformity, scoliosis. And many of them have problems with skin ulceration. They have position problems in lying, sitting, and standing, and they have an increased risk for fractures. And it has for many years been known that hip dislocation is preventable, at least in the individual child. So we did an inventory of all clinical reports at all departments in our area to find all children with the cerebral palsy, to find all children with a suspicion of cerebral palsy and give them a diagnosis. And this inventory is repeated every 4th year. And the prevalence of cerebral palsy in our area is 2.4 per 1,000 live births, and that corresponds well to other studies in Europe. And together with the physiotherapists, occupational therapists, hand surgeons, and neuropediatricians in the area, we created the first draft of the program in CPUP. In the program, the child's local physiotherapist and occupational therapist measure and report the child's gross motor function, hand function, the range of motion in most joints, measured in a standardized way with the goniometer according to a manual. They measure the muscle tone in many muscle groups. They report the child's actual treatment. And all these reports are web-based. And this is the follow-up schedule for the PT and OT report. It's based on the age and GMFCS level. All children in GMFCS level 1 are examined and reported once a year up to 6 years of age, and then every 2nd year. And those in GMFCS 2, 3, 4, 5, they are examined twice a year up to 6 years of age, and then once a year. We have also set up guidelines for reaction according to traffic light system, as I indicated in the beginning. In this guidelines, a green value means that this is okay, no worry, just keep on the actual treatment and follow them according to the program. A yellow value is a warning sign, where you should consider more intense treatment or changed treatment, or at least a more close follow-up. And a red value, that means that you should do something unless there is some contraindications to do so. This is an example. The limits are based on the GMFS system. This is an example for the hamstrings in an individual in GMFS level 1. And the team, after a measurement, they receive a report showing the child's actual and historical result graphically. And that means this makes it easy to follow the development. And if we add this guidelines, it's even more easy to see when something happens, to react and act early. As we identify the contractures early, it's often possible to treat them non-operatively by good positioning, by orthotic treatment, or by serial casting. Of course, sometimes we have to do muscle tendon lengthenings, but we try to avoid it, at least in the young children, because the price for that is a weaker muscle. The hips, they need radiographic examinations to detect a displacement. And we follow the hips with migration percentage, as most people do. And this is our limits for operative treatment. We know that the hips with a migration above 40%, almost all of them need operative treatment to prevent it from a dislocation. We never operate a hip below 33%. And in those in between, it's the child's age, GMFS level, and the development of the migration that decides if they should be operated on or not. This slide shows the age when a displacement above 40% were detected for the first time in our area. And as we see, many children develop a displacement already at 2, 3, 4 years of age. And this is important because this means that to be able to prevent hip dislocation, it's important to identify the children early and give them an early hip radiograph examination. The risk of hip displacement is also related to the GMFS level. This is shown in our cohort, and Graham and his team in Australia have shown exactly the same result. And as you see, we have no child in GMFS level 1 with a displacement above 40%. So our follow-up schedule for radiographic hip examination is based on age and GMFS, just as the OT and PT reports. Those in level 1 are not examined radiographically unless the PT report shows a decreasing range of motion, increasing muscle tone or pain or something. Those in level 2 are examined at 2 and 6 years of age, and those in level 3, 4, and 5, they have annual examinations until 8 years of age. And after 8 years, we continue to follow all of them, but the schedule is individually based on the GMFS level and the result of the previous examinations. It is important for the hip prevention that the child is positioned well in lying, standing, and sitting. Most of these children are in level 4, spending most of their lives in sitting and lying position. And many of them are not able to change position without help. So we try to keep them in extension and abduction when possible. But If the displacement is more than 40%, we have to operate. And the options for operations are adductor psoas tenotomy, soft tissue release, and proximal femoral osteotomy and pelvic osteotomy. When we started in 1994, all families in our area with a child with cerebral palsy, born 1990 and thereafter, were invited to participate. And more than 95% of all families accepted to participate. But some of those born in 1990 and 91, they were already too old for hip prevention at that stage. So we regarded them as a historical control group, showing the result of the way we were working before. And after a few years, we realized that this way of working improved the collaboration between all the different professionals. We spoke the same language. We had the same definitions. We had the same reports to look at and discuss. We also analyzed that we were able to detect hip displacements before they dislocated. And we were able to detect contractures early. And after 10 years, we made a new follow-up. And before I show the result, we must remember that if we don't do anything, the natural history is that about 15% of the total population of children with cerebral palsy will develop a hip dislocation. And if we look at our children born 1990 to 91, we had 10% hip dislocations. That means that we saved 1 out of 3 from a dislocation. But of the 210 children born between 1992 and 1997, we had only 1 child with a hip dislocation, and that is 0.4%. We also found that the number of children with a WED value contracture decreased from 18 to 8%. And the number of operations for contracture was reduced significantly. That was partly a result of the program, but we must know that during these years, the new techniques to reduce spasticity were introduced. Baclofen pumps, rhizotomy, botulinum toxin. The number of children with windswept deformity were reduced, and the number of children with scoliosis with a cob angle above 20 degrees were reduced. And this is not strange because it's the same muscle groups. It's then an imbalance between these muscle groups that creates hip dislocation, windswept deformity, and scoliosis. And now this year, we have done a 20-year follow-up of this hip surveillance program in southern Sweden. And now there are 689 children born 92 to 2007 that we have evaluated. And now we have 2 children with a hip dislocation. That means 0.3%. These 2 children were both detected with a displacement, but they were both regarded to be in too bad medical condition to do preventive surgery on, and they later displaced. Of those 689 children, we operated 91, that's 13%, with preventive surgery. The first operation was adductor psoas release in 51 and varus osteotomy in 36. And of those treated with adductor psoas release, we did a second operation with a varus osteotomy in 25. And of those 25, we did a second osteotomy in 5. Of the 36 children treated with osteotomy as the first choice, 10 had a second osteotomy with a second varus osteotomy. In this group, in this cohort, we have only done 2 pelvic osteotomies. And I think the reason for that is that we detect the displacement at an early stage before the acetabulum get the dysplasia. So this seems good, but there are still many questions. Oh, sorry. Most operations were done in young children, as you can see on this slide. And the operations were also related to the GMFSS level. And this corresponds well to the risk factors I showed you before. Almost no one in GMFSS level 1 had surgery, and more than 50% of those in GMFSS level 5 were operated on. There are still many questions left to answer. Regarding the adductor psoas release, we don't know when that operation is the best choice. We don't exactly know what muscle we should operate on. We don't have a full agreement if we should do a iliopsoas tenotomy or a lengthening. And regarding femoral osteotomy, we don't know when that is the method of choice. How much varusation should we do? How much shortening? How much derotation? Should we operate on both hips even in unilateral displacement? There's no agreement so far. And pelvic osteotomy, when should we do that? And what type of osteotomy should we do? So this was the situation in 1994. And now, after 20 years, the map looks like this. So the program is now used all over Sweden, Denmark, Norway, Iceland, and Scotland. And it's also used in New South Wales, except for the radiographic hip surveillance. In Sweden, we have 3,500 individuals in the program, and they represent more than 95% of the total population, born 1992 and thereafter in southern Sweden. I have excluded those, the historical control group, and the total population born 2000 and after in the rest of Sweden. And at present, we have 13 children with the hip dislocation in Sweden, and that is 0.4%. It's the same figure again. So this means that the rest of the country use the same program and have the same result. In Norway, they use the same program, and Terje Terjesen in Oslo analyzed their result, and he found that they had a somewhat higher proportion of dislocations. They had 4%. And the reason for that was that they had a long waiting list for surgery. So they identified the problem at the yellow stage, but during the waiting for surgery, some of the children got red. So this shows nicely that some of these children, they need a fast track to treatment. We can't wait in all cases. So we must have an organization for that as well. So in Norway, they analyzed the result, they identified a problem, and they changed their organization. So this is a perfect quality control they have done. In total, in these 5 countries, we have now 6,000 children in the program. And this cohort will increase by about 600 cases, 600 children each year if we look at the birth rate. And this is, I think, a goldmine for research because we follow all the children the same way. At the same time as we enter data into the program for follow-up of the individual child, we enter data for follow-up and research. And it's important to know that this is not a treatment program, it's a follow-up program. We don't tell our colleagues what to do. We tell them when they should do something. We recommend them to do something at different stages. And the reason for that is usually we don't have evidence to say exactly what to do. But in the future, we can compare the different methods that are used, and hopefully in the future we can sort out those methods that are not so effective and use the effective more than we do now. The young children that we started to follow in 1994, they are adults now. And we know that adults with cerebral palsy, they are still at risk of a gradually reduced function, reduced range of motion, pain and fatigue and so on. In other words, adults, they also need a standardized follow-up. And we have created now a follow-up program for adults as well, and it's used at present in Sweden and on Iceland. Adults, I don't think they need so close follow-up as a growing child, and we don't have exactly the same measurements, but they are followed. So this is the present situation for CPUP. We have several plans for the next year, and I would like to mention a few of them. We know that we can prevent hip dislocation, but are we sure that all these children need preventive treatment? Are there some of the children we operate with preventive surgery that would not dislocate? Are there some of the children that will dislocate but without suffering? We have to answer this. And Uni Narayanan, he has initiated a an international multi-center study to answer these questions. And I think that's a very important study, and we are a part of it. But what we want to do is that we want to predict those who need treatment with as high sensitivity and specificity as possible. And we are now developing a risk score for hip dislocation based on all longitudinal data that we have in the register, analyzing a list of potential predictors for hip dislocation. We also plan to improve the spinal follow-up. By preventing hip dislocation and windswept deformity, we can delay or prevent some scoliosis, but not all. In the past, an operation for scoliosis included a long fusion and a reduced spinal growth if a younger child were operated. So in the past, it was sometimes an advantage to delay surgery, even if the price was a greater curve at time of surgery and a more demanding operation. But with the new techniques, it is possible to operate with a short fusion and a long fixation that allows for growth. That means that we can operate earlier if we know that there is a need for it. The risk for scoliosis is also related to the GMFS level. And many children start developing scoliosis at a quite young age. So if we can predict, similar to the hips, those who will need surgery, it will be possible to treat them earlier when they still have a yellow curve magnitude. So hopefully we will create a risk score for scoliosis as well in the future. This program works well in the countries involved at present. But the healthcare structure and the social structure makes it easier or harder to run it in different areas. And the program must, of course, be locally adapted to the different contextual factors. Kirk Graham and his team have a successful hip surveillance program in Australia that has several similarities with our program, but there are also differences. And that's not strange because we live in different parts of the world and we have different contextual factors. We have done many years ago a cost-effect analysis in southern Sweden, and that study showed that this way of working, of preventing hip dislocation, is cost-effective. But now we plan to analyze the whole program with a health economic model in the countries involved. And by using economic and organizational contextual factors, we will analyze the feasibility and produce a roadmap of introducing this program in those areas who are interested. So in summary, with 20 years experience and development of this program, I feel convinced that this guided care makes the treatment of people with cerebral palsy less complicated. And I feel convinced that it improves the outcome for people with cerebral palsy. The development of this program is a teamwork with many members in all these countries. So at the same time as I thank you all for listening, I would like to thank all my colleagues for their work and collaboration with this program during the years. Thank you.